It's going to be difficult to follow on the brilliant oratorial skills of Professor Sir Magdi Yakub and Dr. Ashok Hishikar, but I'll try my best. The Sadasivam oration was instituted to honor late Dr. C.S. Sadasivam, who was a pioneering surgeon, teacher, and mentor. And it would be appropriate in that light to pay my respects and to acknowledge my teachers and mentors. Professor N. Gopinath, who's sadly no more with us, was a visionary surgeon, a great teacher, and a mentor to many of the cardiac surgeons today in our country. He was incidentally also the first Sadasivam orator in 1982. I was fortunate to encounter him early in my medical career, in fact, as a medical student. And it was he, in fact, who kindled in me the fire for cardiac surgery. Then came Professor Venugopal and Professor I.M. Rao, who taught me the first basic steps of cardiac surgery. And I acknowledge Dr. Sampath Kumar and Dr. Balram Iron, who held my hand during those turbulent early years as a young cardiac surgeon. The turning point in my career, however, came in 1989 when I encountered Dr. Roger Mee, who offered me a year's fellowship in Melbourne. And that paved my way to choosing congenital heart surgery as my future career. He was a master surgeon, a pioneer of sorts, a great teacher, and above all, a philosopher who taught that cardiac surgery was not all about fixing hearts in the operating room, but had a much deeper meaning. Along the years, he's continued to remain an advisor and a mentor, and I gratefully acknowledge his contribution to my career. With that introduction, I'll move on to my presentation. I have no disclosures, and all photographs that I'll be showing in my presentation are with permission. I'll start my talk with stories of 3 young lives. This is Akshay, presently a 19-year-old young college student, a music buff, as you can see. This is a photograph I took on him in his 18th birthday when he sang a song for me. But he has an unusual background. Akshay was born in 1992 and at day 1 of age was diagnosed to have detransposition of great arteries. A cardiologist then did an emergency septostomy at 12 hours of age, which didn't last the night. I was called in the middle of the night saying that he's desaturating. Like a young bravado, I went and did an arterial switch operation on his first day of life in the middle of the night. Totally unknowing what the future would hold. At that point of time, he was the youngest survivor of an arterial switch operation in our country. Today, he looks like a perfectly young, normal lad. He's in college. This is Snigdha, who's now 22 years old. She was born with a corrected transposition intact septum and had progressive left AV valve regurgitation producing pulmonary hypertension. When she first came to me, she had been through several rounds of hospitals, had been turned on for surgery, and she was 3 years old. And in yet another act of bravado, I did a double switch operation on her. She was the first survivor of a double switch operation in this country. Today she's 22. She's in college. But she's not doing scholastically very well. She has an attention deficit disorder. And as you can see from the photograph, also an eating disorder. This last very bright-looking young gentleman is 18 years old. He first came to me when he was almost 10 months old. His parents brought him. He had a single ventricle mitral atresia, increased pulmonary blood flow, and restrictive ASD. I dissuaded the parents from undergoing any surgical procedure, but they were insistent. So we started a staged surgical program towards a Fontan circulation. He had a atrial septectomy and a PA band in 1996, followed by a Glenn in 1998. In 2003, he underwent an extracardiac Fontan. 2009, we saw that his bulboventricular foramen was restricting, so he went a fourth open heart surgical procedure and had an enlargement of the bulboventricular foramen. 18 years of age, 4 open heart surgeries already. He's young and bright, studies in the US, and is doing extremely well scholastically. This, and there are countless others who are in the same situation. Survivors of complex or simple congenital heart surgery, entering the threshold of adult life. And when they come there, they ask me, 20 years have gone, so far so good. Now, Dr. Iyer, what about the next 20 years? Are we fit to meet the challenges of adult life? Can we marry and raise children? Do we need more surgeries? And will we need more medical care? If so, who is going to pay for that? Can we get medical insurance? And countless other questions. And we sit back and think, that, do we have all the answers? So that brings me to the topic of my discussion, children, heart defects, surgeons, and God. Because these are all children who have defied destiny. And we played a role in that. But we realized that we need to play an ongoing role. It's almost 6 decades since Walton Lilly-High opened the gateway for the surgical management of congenital heart disease. And over the years, we have steadily brought down the mortality for correction of congenital heart disease, which has prompted and encouraged us to increase the level of complexity of the cases that we take on. We try and correct congenital heart defects at a younger and younger age, trying to fix almost everybody by the time they reach the first birthday. Low weight, young age no longer deters us, and we successfully managed to treat open heart surgical problems even at 1 day of age. And if we get into trouble, we don't hesitate to put them on artificial life support and use ECMO. Complex lesions like this, pulmonary atresia, no central pulmonary arteries, collateral difference circulation, are corrected by ingenious methods of unifocalization. And even lesions like corrected transposition, any complex defect that nature wants to throw at us, we are ready to meet the challenge and devise a complex surgical procedure to try and treat that. So the list of complex surgeries goes on and on. Roscoe procedure for LVOTO, double loop translocation for TGA, VSTPS, Norwood operation, staged repairs for hypoplastic left heart syndrome. We brought down the mortality levels to levels comparable to that of adult heart surgery. In our own center, we've persistently maintained operative survival of over 98% for all forms of congenital heart surgery. In for a lesion like tetralogy, for example, the mortality over the years has been brought down to almost 0%. The mortality in the last 800 cases being 0.3%. But having spectacularly achieved these early results, what happens to these patients late after surgery? There is unfortunately a great variance in the perception of late outcome when we compare the physicians and the surgeons' perspective with the perspective of the parents and the children whom we operate upon. As physicians, we tend to focus on survival. We tend to focus on numbers of morbid events. But what the parents and these patients are looking for is quality of life. And what they mean by quality of life, parents, when they look at their children, they're focusing on scholastic performance. They want their children to be able to participate in sports. They want them not to have dependency on medication and repeated surgeries. They want them to have good employment, get married, have children. And there are other social issues like insurance, psychosocial events, self-image, etc., which play an important role in their minds. We are more used to looking at graphs like this. Survival with the Fontan operation current era, we expect an 85% survival at 20 years of age. Or we look at morbid events like flutter-free interval of patients following a Fontan operation. But what my 10-year-old patient who's had a Fontan operation wants to know is, can he go on this roller coaster ride very safely? And will that affect his Fontan circulation? Now, these are questions that we need to answer at their level, and answers are difficult to find. Almost most papers just deal with mundane survival curves and morbidity curves. There are very few articles which actually deal with quality of life after surgery. And this is probably one very comprehensive study which came from Finland, talking about 6,500 patients or so. All patients operated in Finland and followed up to 45 years and looking at their survival and quality of life. And although one may argue that these were patients operated in an earlier era, but the graph reveals something very sinister. The patients with simple heart defects can expect a fairly long survival, although not entirely normal. But those with more complex forms have a very steady and a rapid attrition rate over the course of time. And although quality of life indicators like occupational status, education level, and marital status may compare well with what is predicted and expected, these only pertain to those with simple heart defects who have actually survived on to adulthood and not perished along the way. So when we look at data on long-term follow-ups, there are several problems that we encounter. Firstly, how long is long? We are often satisfied with 10-year, 15-year, 20-year survival. But when a mother brings in her neonate for surgery, she wants to know that is her kid going to live only for 20 years or will he be able to live for 40 or 50 years? The data reflects only surgical cohorts, and we don't look at patients who are unoperated or patients who had concomitant medical therapy. The management strategies unfortunately change along the way, so that when we look at a 20-year follow-up of patients operated 20 years ago, we realize that we are no longer doing those operations or we're doing them differently. And what we do today as an operative procedure and with a theoretical projection that this is what's going to work may not actually work out that way. And lastly, there's a wide variation in the results that come out from different institutions. Let's look at what happened with surgery for tetralogy of Fallot. In the 60s, everybody had a plealotoxic shunt initially and then had a second stage correction. In the 70s, we started doing primary total corrections, but used a transventricular approach with large outflow patches. And then we realized that was probably not the right way to go. And in the 80s, we started a transatrial approach, trying to repair most of the lesions through the transatrial route. In 1990s, we thought that operating them in the neonatal period was probably a good idea. And then in 2000s, we realized that pulmonary regurgitation was an increasing problem. So we should probably do aggressive preservation of the pulmonary valve, maybe in fact leave some residual stenosis behind. And now we feel that all of them should receive an early pulmonary valve replacement because we don't know how that right ventricle is going to respond to a late pulmonary valve replacement. So we have elegant graphs like this, which show that over the course of years, we've dramatically improved the survival in tetralogy of Fallot. But then you see here, as we go up on the graph, the duration of follow-up is shorter and shorter. And as we know, and as illustrated in this graph, that some problems may actually come on very late. We were very happy with the early outcomes of tetralogy of Fallot, even patients being followed to 15 to 20 years. But this 36-year follow-up of 490 patient survivors of tetralogy fellow showed that the attrition rate increases dramatically once they cross 25 to 30 years of follow-up. So a procedure which may serve well early in life may actually become lethal when these patients actually enter the prime of their adulthood. And look at the variation in the different centers as far as late mortality rates and late morbidity rates. These are late mortality rates from several centers with varying degrees of follow-up. And the late mortality varies from 1% to 14%. Obviously, it's very difficult to come to any logical conclusion with that sort of data. Sometimes it takes over 20 years to determine that a particular procedure is actually detrimental. And it took us 20 years to realize that placement of an outflow patch was going to be detrimental in the long-term outcome of tetralogy fellow. It took us that same time to realize that chronic pulmonary regurgitation was not as innocuous as it was thought to be, and that it leads to progressive right ventricular dilatation, failure, and forms the basis of arrhythmias and sudden death. We didn't realize that a patch that we put, which looks so innocuous on the operating table, will at the end of 30 years look like a ghastly fig tree like this. Yet we continue to persist in putting outflow patches, which are big, producing pulmonary artery bifurcation stenosis like this, or resulting in an aneurysm like this. We also realized later that the scarring that we produce by interfering with the right outflow forms the substrate for arrhythmias, which could be fatal arrhythmias or could lead to syncope. And then now we try and resolve those problems by trying and placing a pulmonary valve in these patients and doing an extensive reconstruction of the right ventricular outflow tract. It's been 30 years and we don't have a perfect solution for the right ventricular outflow tract. We're now more energetic and more enthusiastic, and we devise ways and means of placing a pulmonary valve without a resurgery. And we're focusing on developing a percutaneous pulmonary valve implant, which is now fairly extensively being used. But now we bicker about the indications for pulmonary valve replacement. We still don't know whether we should replace it early or should replace it late. And we don't know whether actually replacing the pulmonary valve is going to restore that right ventricle to normal. But it's going to happen. That even in my own personal short experience, the number of reoperations for tetralogy is steadily increasing. And I anticipate that going down, more and more the patients that I've operated on will come back for reoperations. Very often the solution that we seek today or we devise today may turn out to be a wrong option 10 years later. Take the example of transposition of great arteries. We started off with the Blaylock Canal operation. And as you heard Professor Cherian this morning, the Senning operation was at one time touted as the solution to transposition. But we soon realized that that was not the way to go. And the arterial switch operation took a foothold in the 1990s. And to make the arterial switch operation more convenient, we devised a Lecomte maneuver of bring the pulmonary artery in front, much against what nature intended. And we thought that would work perfectly all right. In fact, today, I don't think anybody does an arterial switch operation without doing the Lecomte maneuver. And 10 to 15 years of follow-up, this seems to work perfectly well. The pulmonary artery is growing, lies in front. Go further into 20 years follow-up, and this is what you're likely to see. The pulmonary artery is not where it is supposed to lie. It's stretched out by a growing aorta. And now we have a whole new set of patients who require pulmonary artery reconstruction 20 years after their arterial switch operation. So we probably have to think a little more seriously about the suggestion by a Taiwanese surgeon who's been trying his very best to propagate his spiral technique of pulmonary artery reconstruction, in which, with a slightly more complicated method, he retains the pulmonary artery in its actual position and goads us to try and do the procedure retaining nature's spiral flow, which hopefully will reduce the late problems of pulmonary arteries in patients undergoing arterial switch. So there are several factors which influence late outcome, starting from the basic defect itself to the timing of intervention, to the way we correct or palliate the procedure, the adequacy of correction, whether we use processes or not, and how well we have preserved the myocardium at the time of surgery. But no matter what, our patients whom we operate upon are destined to face major long-term morbidities like sudden death, re-interventions for surgery, arrhythmias, need for pacemaker, heart failure resulting from residual lesions or progression of pulmonary vascular disease, endocarditis, and neurocognitive disturbances resulting either from the basic defect or from the problems that we have created in the operating room. And as we can see, that the further our surgical procedures and techniques move away from the heart that nature designed, the greater and greater problems that we can expect on late follow-up of these patients. And it's imperative that we recognize the fact that the children we operate upon do not just want to be a dot on a survival curve. They want to live life. And if we recognize that essential difference, then although the Gita may advise us that we are supposed to do our duty and not bother about what the outcomes, but I think recognizing that essential difference is what will be the turning point in the lives of the children that we operate on. And they will thank us for recognizing that difference. Thank you very much for it.
Thank you, Dr.